Hello, we're palliative neurologists.
Jessica Baker.
Jessica Bespris.
And I'm Neha Kramer. We're here to teach you how to use best case, worst case, neuro, a communication tool that translates your clinical knowledge into meaningful stories. This helps clinicians and families make decisions in the face of serious neurologic illness with prognostic uncertainty. As an example, we're presenting a case of acute ischemic stroke. It starts with your patient, Esther, an independent 70-year-old with atrial fibrillation, heart failure, hypertension, chronic kidney disease, and a history of transient ischemic attack. Esther's daughter found her this evening on the kitchen floor, weak and unable to speak. She's intubated for airway protection. Her NIH stroke scale score at the time of arrival is 28x, and imaging demonstrates a large, completed, left hemispheric ischemic stroke. After consideration, you determine she isn't a candidate for thrombolysis or mechanical thrombectomy. Esther is admitted to your neurocritical care unit. You're meeting Esther and her family at a moment of crisis. Difficult decisions lie ahead. Understanding what's important to Esther will be critical for making treatment recommendations. From her family, you learn Esther is proud of her independence, garden, and grandchildren. On Esther's 6th day in the ICU, she remains intubated, lethargic, and not following commands. We need to discuss life-sustaining therapy such as tracheostomy and feeding tube placement with her daughter. First, set the stage that this stroke is bad news. It's essential that Esther's family understand that even with the most intensive care possible, her life will be very different than it was before, if she even survives this admission. How can you make this clear?
You might say, your mother has had a severe stroke and hasn't yet shown signs of recovery. I'm worried this stroke will permanently limit her independence and ability to interact with others. Pause here to allow Esther's daughter time to absorb the impact of this bad news. Then you might say, I wish I had better news. We have a tough decision to make about your mom's care. We need to start thinking about what her future looks like, and I want to make sure you understand her treatment options.
As a neurologist, you recognize the broad range of Esther's possible outcomes. With this uncertainty, how can you counsel families and help them make important decisions? The best case, worst case approach and the corresponding graphic aid helps present options in situations with prognostic uncertainty.
Here's the graphic aid. Documenting key elements in it may seem time-consuming, but it is critical. Patients and families frequently use it to discuss options amongst themselves and other advisors. The diagram extends your reach into those conversations, improving their quality and helping families reach consensus. For Esther, you're presenting two options: continue life-sustaining therapy with tracheostomy and feeding tube placement, or transition to comfort-focused end-of-life care. For each option, draw a box and a star connected by a vertical line. Imagine that these represent 95% confidence intervals where the actual patient experience is almost certain to be included within these anchors. A star represents what her life might look like if everything goes well, the best case. The box represents the worst case. Somewhere in between lies most likely. Most likely may be far away from, close to, or the same as the best or worst case. Use your knowledge of outcome probabilities to estimate where to position most likely on the line between best and worst. Combine what you know about the patient's overall health with your understanding of their neurological injury and likelihood of recovery to give a realistic range of possible outcomes. So how can you help Esther's daughter understand what life might look like if she opts for tracheostomy and feeding tube placement? Translate your knowledge of expected stroke trajectories into a story. Telling a story helps patients and families imagine an unfamiliar experience, like being bedbound on machines, so they can make decisions based on what's important to them. Show the probability of these events by positioning the most likely outcome. If Esther undergoes tracheostomy and feeding tube placement and everything goes as well as possible, what would life be like? How much recovery might she expect? Where would she receive care? How might life change in the short and long term? Tell the story.
In the best case, the procedures go smoothly. She'll be in the hospital for another week, then discharged to a facility where they will wean the ventilator and help Esther breathe on her own. With months of therapy, she'll regain the ability to walk short distances and adapt to residual right-sided weakness, to live with minimal assistance from family. She'll be able to recognize her grandchildren and follow simple instructions. She'll communicate her basic needs, though she will have difficulty understanding complex conversations and expressing her thoughts. Eventually, she'll have her feeding tube removed. If all goes well, she'll return home and stroll outside in her garden with her grandchildren. Now, let's consider the worst-case scenario. The tracheostomy and feeding tube are placed without complications, but she quickly develops insurmountable complications such as sepsis. Esther becomes unresponsive and dies in the hospital within days to weeks.
Now let's talk about the most likely scenario. Using prognostic tools, you conclude that Esther has a 45% chance of survival at 30 days, but only a 25% chance of survival at 1 year. At 3 months, she has a 60% chance of being dependent on others for care, confined to a bed or wheelchair, or dead. To illustrate, use your knowledge of probabilities to place a mark somewhere along the line to indicate its relation to the best and worst case. For Esther, it's probably somewhere close to the middle. Remember to acknowledge her baseline health and note her underlying heart failure and chronic kidney disease may complicate her recovery. Telling stories allows patients and families to visualize what might happen in a way that numbers alone cannot.
You could say something like, most likely, Esther will make some improvement over the next few months. She'll be able to communicate basic needs and briefly get out of bed, but she'll continue to rely on the feeding tube for all nutrition. Even with intensive therapy, she'll be unable to walk and will require care around the clock, either at home or in a nursing home. She'll be unable to tend her garden or read to her grandchildren. Setbacks such as infection will require transfer to the hospital for treatment. Because of her underlying heart and kidney problems, these hospitalizations will take a toll, with each one leaving her more debilitated than before. It is unlikely this stroke will let her live longer than 1 year.
Now repeat these steps describing the best, worst, and most likely stories for comfort care. Esther's daughter has shared that her mother would want to spend the end of her life at home.
You might say, in the best case scenario, Esther will breathe comfortably on her own after removal of the breathing and feeding tubes. Her eyes will open at times, but she won't be able to speak. If she indicates a desire to eat, she may be able to enjoy a few bites of soft food like ice cream or applesauce. We'll use medications to treat pain and shortness of breath. She can transition home with support from hospice, where I anticipate she'll survive for days to a short number of weeks. We hope her grandchildren can gain closure from being present for her final moments. In the worst case scenario, pain and shortness of breath after removal of the breathing tube may be difficult to control, requiring frequent medication adjustments. If this occurs, she'll probably die in the ICU within hours. Most likely, her breathing tube will be removed, and she'll transition to a hospice room outside of the ICU. With family at her bedside, Esther will receive attentive, comfort-focused care. Your family can bring pieces of home to her bedside, gather around, and honor her life. Though she may not participate actively, she may sense your presence. Her pain and breathing will be well controlled with medications, and she'll die over the next few days.
Create an opportunity for Esther's daughter to react to these stories. You might say, I've said a lot. Tell me how you're thinking about this. If Esther's daughter just doesn't want her mother to undergo tracheostomy or feeding tube placement, you don't have enough data.
You might reply, it sounds like you've already decided. Help me understand how you arrived there.
Eliciting these preferences will give you essential access to their thought process. When you know what's important to your patients, your recommendation will align with their values and goals. Esther's daughter can tell you what she thinks about the scenarios you described. Perhaps her mother fears being hooked up to a machine for even a few short weeks or losing her independence. Maybe Esther would never want to be unable to run after her grandchildren in her garden.
Based on what Esther's daughter has shared, it's your job to make a recommendation. It's not okay to simply present options and expect patients to choose. Match your knowledge about disease and treatment with what you know about your patient's preferences and values.
You could say, I understand your mother's independence is important to her, and she has strong feelings about being dependent on machines or caregivers, even temporarily. I'm worried that the burden of these procedures is greater than she would want, especially since the most likely outcome would leave her dependent on others, and with a quality of life she wouldn't consider acceptable. I recommend we don't do these procedures. Accept that we have come to the end of her life and focus on her comfort.
Let's summarize. First, set the stage and break bad news. Then, identify a choice, in this case, between life-prolonging therapy and comfort care. Create a graphic aid that illustrates the range of possible stories and share it with your patient and their family. Using storytelling, describe the best, worst, and most likely scenarios. Avoid percentages and statistics. Include the patient's other medical problems in your stories and their impact on survival and quality of life. Elicit preferences. Ask, what's most important to you right now? Once you've learned what's important to your patient, make a recommendation. The stories you tell using the best case, worst case framework let you support patients and families to make value-based decisions in a way that numbers alone cannot. We hope you'll use this helpful tool to tell stories that support families making decisions in the face of prognostic uncertainty.